Hi, good day, good evening, good afternoon, or good morning, everyone. Welcome to the 8th session of Personalized Approach to Sepsis Management. My name is Mahal Jaid from Eastern Mediterranean Alliance. It's my pleasure to introduce my colleagues who's going to share with us about clinical trial and precision treatments. Our first speaker will be Bruno Francois. Bruno is a leading intensivist from the Dubuque University in France. His clinical and academic interest in community-acquired pneumonia and sepsis prevention in critically ill patients. He's a known author and leading investigator in multiple publications related to sepsis prevention and community-acquired pneumonia. He's going to talk about the TREM1 pathway. The floor is yours, Bruno. Go ahead.
Thanks a lot, Maha. Hello, everybody. So, as mentioned, my name is Bruno Francois. I'm from Limoges, France. So let's talk a little bit of TREM1. So TREM1 is expressed by innate immune cells, and it works in conjunction with the TLR receptors. And when there is an activation of the TLR receptors, there is an activation then of the TREM1 receptors, and this results in inflammation with the production of pro-inflammatory cytokines. And when there is an overactivation of the TREM1 pathway, the TREM1 receptors, this results in immune dysregulation. This is a really potent cytokine releaser, as illustrated, is especially when activated in correlation with TLR. So TREM1 is a really important pathway in sepsis. And its activation after TLR engagement following LPS challenge. This results in endothelial cell activation, but also activation of the coagulation. And if there is an overactivation of the TREM1, it promotes not only dysfunction of endothelial cells, but also immune dysregulation, and at the very end, organ failures, as it can be seen in septic shock. Interestingly, TREM1 is not only an important pathway for sepsis and septic shock, but it's also an important pathway in COVID, and as it has been shown by Da Silva Neto in viruses a few years ago. When TREM1 is activated, there is a specific biomarker, which is sTREM1, which is released by the proteolytic cleavage of the TREM1 receptor following its activation. And as you may see on the left-hand side of the slides, this is a pretty strong correlation between the sTREM1 release and the TREM1 pathway activation. So, in fact, sTREM1 is a really interesting biomarker, a sort of companion diagnostic of the TREM1 pathway activation. This has been validated externally on two cohorts that you may know, the Adrenos cohort and the Mars cohort. One of on severe sepsis and septic shock, and the other one, the Adrenos cohort on septic shock. And as you may see, there is a correlation between the different quartiles of sTREM1 and the day 30 mortality. So, in fact, sTREM1 is an interesting prognostic biomarker when after sepsis. Similarly to the pathophysiology, there is sTREM1 is also a prognostic biomarker in COVID, as illustrated by this study from Da Silva Neto in Brazil at time of COVID. And the most critical is the COVID, and the higher is the sTREM1 marker at baseline. Several different drugs has been tested to modulate the TREM1 activation, but only one has reached human clinical development, which is the non-gibotide. In fact, non-gibotide is a small peptide that acts as a decoy of the receptor and inhibit TREM1 activation, and it's a specific inhibition. Thanks to an interesting safety profile in in healthy volunteer. The drug has been tested in a phase 2A, small trial, so difficult to have a strong opinion, and results have to be taken cautiously, but in a 50 patient phase 2A trial in septic shock, non-gibotide was given for up to 5 days, and it has demonstrated a trend favoring non-gibotide when compared to placebo, both on the day alive and free of ventilator support, but also on the length of stay and the mortality at day 28. So in fact, S-TREM1 is not only a prognostic biomarker, as mentioned before, but it's also a predictive biomarker, which can support further development. So following this phase 2A, the drug has been tested in phase 2B, much larger trial, 355 patients, more or less the same type of design, but only the population of interest was the one with high level of S-TREM at baseline, defined by a level of S-TREM1 or above 400 picogram per ml. And primary endpoint was delta SOFA by day 5, 3 group, 1 low dose, 1 high dose, and 1 placebo group. Few classical secondary endpoints such as day 28 mortality, duration of organ support. And these are the results. So the trial did not reach significance, both in the overall population on the right side and in the IS-TREM1 on the left side. But there is a trend favoring the high dose when compared to placebo. And interestingly, when gaming the level of S-TREM1 at baseline, the predefinition based on the result from the phase 2A was 400 picogram per ml, but when gaming, so in fact, when considering higher S-TREM1 value at baseline, around 600 picogram per ml, it's become significant, both in terms of delta SOFA and mortality. And when looking at the very high S-TREM1, defined by the S-TREM1 level above 656 picogram per ml, which correspond to the 55th percentiles, this results in this. So this is a small subgroup. It's a post-hoc analysis. So again, it has to be taken cautiously, but it's more or less 100 patients, 50 in the placebo group, 50 in the non-gibotide group. And as you may see, there is an effect and a pretty strong effect in terms of delta SOFA, but also there is a trend in terms of patient alive and free of organ support at day 20. Also a trend in terms of all-cause mortality and also in terms of ICU stay. Interestingly, and because of the pathophysiology, which is similar to sepsis, non-gibotide has been tested in COVID. So more or less the same type of design, patient with a severe COVID receiving high flow oxygen or invasive mechanical ventilation, 2 group, 1 non-gibotide, 1 placebo group. Primary endpoint was improvement of the 7-point ordinal scale. And as you can see, there is an interesting, so the population was lower than expected because of the end of the pandemic. But more or less, there is a numerical difference in terms of mortality, both when considering the overall population, but even with a much higher effect in the IS-TREM1 population. So to conclude my talk, I would say that now there is a strong evidence that TREM1 is an important pathway in the ICU, especially, and it drives immune dysregulation in infectious disease, including sepsis, septic shock, but also COVID, and possibly, and it has to be confirmed, other viruses. It's a prognostic biomarker, both in COVID and in septic shock, and it's a really promising specific marker for precision medicine approach. And last, non-gibotide is safe and well tolerated, and it has proven a significant improved survival at the day 28 in COVID, and a reduction of organ support at day 28 in sepsis and septic shock. And with that, I will be happy to take any questions.
Thank you, Bruno. There is no question from the participant in the chat box, but if you briefly, I have a questions related to the term one. When do you expect to see it part of the standard prognostication for septic patient, or is it still in clinical trial phase?
Yes, thanks a lot for this question. So we are now moving in phase 3. So it will probably take, I would say, 2 years, global trial, worldwide trial. So 1,200 patients to be enrolled. So not before 2026, 2027.
Thank you so much. Appreciate your participation.
Okay,
we're moving
my pleasure.
Our next speaker is Dr. Carolyn Calfee. Carolyn, she is a professor of critical care medicine from University of California. She did her, she's actually a graduate from Pennsylvania University, did her training in University of California. Her interest in precision medicine and phenotypes treatment in ARDS and sepsis. She is going to discuss with us ARDS, room for precision treatment. The floor is yours, Carolyn.
Thank you so much, and thanks so much for the invitation to be here. These are my disclosures, none of which are particularly relevant to what I'll be talking about today. So we hear a lot in medicine in general and in critical care about how we are on the cusp of the precision era, and this session, in fact, is really about precision medicine and sepsis and critical care in general. This figure comes from a terrific review published in Nature Medicine a couple of years ago about where we stand in critical care medicine, really positing that we are about to enter into this era where, much like Dr. Francois just talked about, we're targeting our patients based on their underlying biology, as opposed to a syndromic classification that we have used for decades. Another way to frame this and think about precision medicine, maybe an older way of talking about it, is lumping versus splitting, right? And this is different, really just a different way of splitting our patients out based on clinical, physiologic, radiographic, or biologic features. Now, when we're talking about ARDS, of course, just like there are lots of ways to slice an onion, there are many different ways to split ARDS. And for decades, actually, we've been talking about splitting ARDS on the basis of clinically obvious phenotypes like direct versus indirect lung injury, diffuse versus focal, COVID-19 versus typical ARDS, and others. And I would say that I think what we're looking for here is not just a way to split our patients, because we can, like I said, think of dozens of different ways to do that, but it's really, like Dr. Francois was highlighting, trying to identify groups that respond differently to treatment. So what evidence do we have within ARDS in particular that we can do this in a meaningful way? And I'll start briefly with talking about clinically apparent phenotypes. Now, probably the phenotype that we think about most frequently in ARDS is basically severity, or the PF ratio. And this is, I think, the most clinically implemented and probably evidence-based way to split our patients with ARDS. And there's a strong evidence base, I think, that both proning and ECMO are really most useful when we target them to our most severely ill patients. Proning to patients who have a PF ratio of less than 150, and ECMO to patients who fit the criteria used in the Eolia trial. Now, some people might quibble with calling this a phenotype since only one parameter is used to define it, but it's, I think, a useful way to talk about starting to split our patients. Now, what about a more complex clinical phenotype like diffuse versus focal ARDS? So this is based on really the chest radiograph and CT. Is the ARDS diffuse, or is it more patchy or focal? And the LIVE trial, led by Jean-Michel Constantin and others, randomized 420 ARDS patients to a personalized strategy based on chest X-ray and CT appearance versus standard care, and found no difference in overall outcomes. Now, this was, I should say, I apologize, a personalized ventilatory strategy. Now, you see the survival curves on the figure at the bottom. The intention to treat or the overall population is on the left-hand side here. However, they found that about 20% of patients were actually misclassified and that the initial assessment of their chest X-ray or CT put them in the wrong group. And when these patients were excluded from the personalized group, that strategy actually appeared superior, as you can see from the survival curves on the right. So I think this is a nice example of sort of the trade-offs we're talking about in precision medicine. On the one hand, the potential for more personalized care, but on the other hand, the potential challenge of misclassifying our patients. Now, the last clinically apparent phenotype I'm going to talk about is a phenotype based on lung compliance. And this is work that's been led by Ewan Gallagher, pictured here from Toronto, as well as others, with the idea that there are different phenotypes of ARDS based on compliance. And in this publication from the Blue Journal from a few years ago, he reported that the effect of lowering tidal volume on mortality in ARDS actually varied with respiratory system elastance. So that if you look on this right-hand figure, as elastance goes up, and remember that's the inverse of compliance, so compliance going down, that's really at the high levels of elastance or low levels of compliance where you see the benefit of a lower tidal volume strategy. However, that was retrospective analysis. So this is going to be tested by Ewan and colleagues in the practical platform trial, which is being led out of Canada and will be conducted at multiple different sites around the world. Ewan, along with Serena Sahatia, Eddie Fan, Neil Ferguson, and others, are leading a trial that will be stratified by low versus high elastance and have ventilator strategies that are actually personalized to each of those, with sort of the hypothesis that it's that high elastance, or rather, high elastance, low compliance group that would particularly benefit from a tidal volume limited strategy. Okay, so those are clinically evident phenotypes of ARDS. Let's talk about biological phenotypes of ARDS. And our group and others have been working on an approach called latent class analysis that seeks biologic phenotypes on the basis that there may be distinct subclasses within a broad group of patients, and asks the question, if you see a data variable with this just observed distribution, does that better fit with the hypothesis that it's one class, or maybe, as you see here in the blue and red lines, two or more classes? This can actually test a hypothesis regarding the best fitting number of classes, may be independent of clinical outcomes, and importantly, is not driven by treatment response. So you're looking at the patient characteristics at baseline and asking whether there's evidence of distinct classes. We've applied this now in 8 cohorts of patients with ARDS, including 6 randomized controls and 2 cohort studies. And in all 8 of these found strong statistical evidence that a 2-class or a 2-phenotype model is actually a better fit for the data than a 1-class model. These 2 groups we've termed hyper and hypo-inflammatory, with the hyperinflammatory being consistently about 1/3 of the patients. And we've called it that because it's characterized by higher plasma levels of inflammatory biomarkers like IL-6, IL-8, TNF receptor 1, and lower levels of bicarbonate, protein C, and systolic blood pressure. Now, I mentioned that clinical outcomes were not used to identify the phenotypes, but consistently across studies ranging from the mid-1990s into the 2010s, we see that that hyperinflammatory phenotype has significantly worse clinical outcomes. I'm showing you here mortality, which is, as you can see, much, much greater in that hyperinflammatory phenotype, even as you see at the bottom in a pediatric ARDS cohort. Now, that's fine and interesting, but I said earlier, I think the main reason we should be seeking these phenotypes is really to try to identify differences in treatment response. And in fact, in retrospective analyses of completed clinical trials, these phenotypes do appear to respond differently to treatment. So in randomized studies, they appear to respond differently to high versus low PEEP, to conservative versus liberal fluids, and to pharmacotherapy with simvastatin. And in observational studies, they appear also to respond differently to corticosteroids in COVID-19. And again, in the lung safe study, though it was observational, to high versus low PEEP in the same manner as in that clinical trial. All right, so that sounds interesting, but what can you do with this at the bedside? You can't do a latent class analysis in your patients, certainly. So how could you look to try to identify these phenotypes, and how could we try to target them in clinical trials? So this is a picture of Pratik Sinha, who's was a postdoctoral fellow with me, now faculty member at Washington University, and has really led the work to try to develop methods to identify these phenotypes in parsimonious models. And he's developed both biomarker-based classifier models that use 3 to 4 variables, as well as clinical data-only classifier models that use machine learning methods like XGBoost to identify the phenotypes. And in retrospective studies, these seem quite accurate for phenotype identification, with areas under the curve of 0.88 to 0.96. However, they still need prospective validation. This is ongoing right now in a couple of different studies. The FIND study being led by Danny Macaulay from Queen's University Belfast, which is seeking to identify these phenotypes using real-time biologic marker measurement in about 550 patients. And here in the US, the I-SPY trials led by Laura Esterman, Kathleen Liu, and Clark Files, which is seeking to do something similar in patients with ARDS and acute hypoxemic respiratory failure. All right, I think I just have 1 more minute left, and so I want to just tell you briefly about a clinical trial that will be starting soon to actually test the hypothesis prospectively that these phenotypes do respond differently to treatment, and that's the PANTHER trial. Again, being led by Dr. Macaulay out of Belfast. PANTHER stands for Precision Medicine Adaptive Network Platform Trial in Hypoxemic Acute Respiratory Failure. This will be an international phase 2 precision medicine trial with real-time biological phenotyping to stratify patients by phenotype. It will be a platform trial with enrollment beginning, we hope, in 2025. The patient population will be adults with ARDS with hyper or hypoinflammatory phenotypes. The initial interventions will use simvastatin or baricitinib with a comparator of usual care and an outcome of 28-day organ support-free days. This will be a platform trial, as I mentioned, with a Bayesian analytic approach, which will take adults with ARDS, stratify them using this real-time phenotyping into hypo and hyperinflammatory, and then both groups will get randomized to standard of care versus a variety of different interventions with interim analyses that can lead either to arms being stopped, arms being progressed, or potentially addition of additional agents. All right, I think that is 10 minutes. So I had a few more slides, but I'm going to stop there in the interest of time, and I'd be happy to take any questions. Thank you so much.
Thank you so much, Caroline. I just want to get your feedback. If you can comment on the relationship between precision medicine and empowering patients and their families to take decision of their care. And linked to that, I also would like to find out if you find non-critical care or non-acute care clinicians is interested in precision medicine to treating infection, because generally speaking, at least the part of the world that I'm practicing in, there is a perception that precision medicine is only for oncology treatment, and there is a long way to go with the precising treatment for inflammatory conditions and infectious conditions such as sepsis.
Yes, what great questions. Maybe let me take the second one first. I agree with you that I think the perception overall is that this is something reserved for oncology. And to be fair, I think the oncologists are frankly decades ahead of us in critical care in terms of the idea of matching treatments to the biology of their patients. But I think we can also turn that around and use that to our advantage and really learn from what they have done in oncology to advance care of their patients beyond just syndromic classification of disease into something that is actually more precise and more biologically targeted. And I think the more we look under the hood in critical care medicine at the biologic heterogeneity of our patients, the more we realize is out there. I think that's a theme we heard in Dr. Francois' talk, and that's certainly one of the themes I was trying to bring out in my talk. To your first question about how this interacts with patients and families being empowered to take more of a role in their care, I don't see those as opposed at all. In fact, my hope would be that it could actually help patients and families understand what we're trying to do to care for their patients when we can make a more rational argument for pairing, for example, a biologically targeted therapy with patients whose biomarker profile indicates that they're more likely to benefit from that type of therapy. So I would hope that it could actually be something that could make our care more approachable to patients, but we'll have to do the work on our side to make sure that we're explaining this in a way that is clear and understandable, and also to make sure that when we do studies in precision medicine, we really enroll a diverse set of patients that represents the full spectrum of patients we take care of in all sorts of different dimensions, so that we don't build a precision medicine treatment that's really only suitable for one small subset of a population.
Thank you so much. Our next speaker is Dr. Sara Cajander. Dr. Sara, she's a clinical scientist in infectious diseases, consultant in Sweden and Örebro University Hospital. She is one of the national experts in COVID-19 and evidence-based management. She's going to talk about reversal immunoparalysis. The floor is yours, Dr. Sara.
Oh, thank you very much for inviting me. So I'm actually an ID physician, and I work in Sweden. And I'll give you a talk about reversal of immunosuppression in sepsis. And here are my conflicts of interest. And first, a short background. We understand today that sepsis patients experience a dysregulated host response to infection, and that some patients who survive the initial acute phase, where the fire is out of control, will be at risk of entering a state of immunosuppression, where the immune cells become tolerant and respond with a weaker immune response to secondary invaders. And this is associated with late phase complications and death. And the dysregulation has a varying severity between individuals and over time. The patients who develop immunosuppression often have signs of chronic inflammation and resembles the immune status of cancer patients. And in the most severe cases where this dysregulation continues, there is an increased risk of secondary infections that are difficult to treat. And this is sometimes referred to as immunoparalysis. And by profiling the immune response, the idea is to identify patients at risk for immunoparalysis. And this can be done by functionality tests, where cytokine responses are measured after challenge by microbial ligands, or by flow cytometry. Immunophenotyping can identify the presence of myeloid-derived suppressor cells, exhausted lymphocytes, and monocytes with low expression of the antigen-presenting molecule, HLA-DR. And in almost every hospital, you can also roughly catch this by identifying a persisting lymphopenia. Okay, so now over to the main question. Can we reverse the state? Well, according to the positive results of preclinical studies and case reports, there are some therapies that have shown potential and proceeded to be tested in randomized controlled trials. And I'll summarize the clinical trials results in some of these therapies now. Okay, so the first one is recombinant interferon gamma. This has been of interest as a low production of it is linked to secondary infections and late sepsis mortality, and it is suggested to increase clearance of bacteremia. But unfortunately, a recent RCT in ICU patients randomized to interferon gamma had a higher rate of secondary pneumonia in comparison to the placebo group, and this study was also stopped early due to safety concerns. And this has raised the question if interferon in fact might be a driver of immunosuppression. And in the study by Kim and colleagues, an excessive interferon gamma in the early phase of sepsis was possibly linked to secondary candida infection. But the negative results of this interferon ICU trial has also been suggested to be related to a lack of correct selection and wrong timing. And the treatment, it was actually given very early, and it was not exclusively studied in sepsis patients. And as you all know, there is a large heterogeneity in the underlying biology of sepsis patients. And this is thought to explain the history of very many negative trials in unselected patients. So because of this, sepsis trials today need to have strategies to deal with this. And the PROVIDE study is one example of a biomarker-guided targeted trial. And in this trial, the intervention of either interferon gamma or the IL-1 antagonist anakinra was guided by the immune status of the patient. But this study had some issues with difficulties to recruit patients and was prematurely stopped. But instead, there is a similar study called Immunosep with a bit adjusted inclusion criteria for immunosuppression that's now ongoing. And hopefully this trial can help us answer if interferon gamma actually reverses immunoparalysis and translates into a clinical benefit. Another immunostimulated therapy is GM-CSF, which stimulates granulocytes and macrophages. In some early studies, it was found to reduce the need for mechanical ventilation in patients with sepsis and to increase infection resolution rates. However, it did not translate into a mortality benefit. And in a more recent study targeting patients with low HLA-DR expression, it did not demonstrate a reduction in ICU infections. But this study was prematurely stopped due to a low inclusion rate. Only 98 patients were included, making up around 20% of the intended cohort. And as many of you know, the PD-1, PD-L1 pathway is a critical immune checkpoint that has been successfully targeted in cancer-related immunosuppression. And in sepsis, there are 2 early phase 1 trials targeting this pathway, but they found no unexpected safety concerns. And they also found that it restores HLA-DR and lymphocyte counts. Another interesting approach to reverse immunosuppression is by vaccinating intradermally with inactivating mycobacteria, which evokes cell-mediated immunity and activates Th1 responses. And this is actually used to clear leprosy infection. And there are 2 small RCTs conducted in gram-negative sepsis with conflicting results regarding secondary infection rates, but with a small trend towards reduced mortality. And some other therapies that should be mentioned are thymosin alpha, a thymus-gland peptide, suggested to modulate and enhance immune function. There is an ongoing large multi-center RCT with more than 1,000 patients that hopefully will be published soon and inform us if this works. Another treatment is recombinant IL-7, which is an anti-apoptotic cytokine that has shown to restore lymphocyte levels, but it has only been evaluated in 2 small studies. And also multipotent stem cell therapy hold promise from results in early phase ARDS and COVID studies, and treatments that shorten the time to clinical recovery of the acute sepsis phase may also indirectly have a positive effect on the development of immune paralysis. For example, an RCT showed that treatment with bioadrenomedulin antibodies led to faster clinical improvement. And at the experimental level, there are some promising novel approaches, such as the IL-4 fusion protein that induces trained immunity and reverses immune tolerance. And according to a recently published systematic review and meta-analysis, including 11 immune cell stimulating RCTs between 2001 and 2023, there was overall no mortality benefit found in the pooled analysis. However, the authors concluded that there was also a low risk of severe adverse events, and that is a good start. But how can we do better? Well, first of all, we need to target the patient populations at the highest risk of immune paralysis, and single biomarkers may lack precision to do this. And instead, we should identify sepsis endotypes by a more comprehensive approach. Because as you know, patients might have very similar presentations clinically, but once you reveal the endogenous signature, there might be relevant differences affecting future outcome. And this can be done by omics technologies. For example, post-hoc analysis of the VANISH trial revealed differential treatment responses to steroids in patients with certain transcriptomic signatures. So to summarize this, there is a lack of high-quality evidence from RCTs for therapies reversing immunosuppression today. And more targeted, adaptive trials are needed, but this may be challenging as the many targeted trials were stopped due to a slow inclusion rate. And to avoid futility, there must be a commitment to straightforward inclusion procedures. And here I think we can learn from the recovery and the REMAP-CAP trials from the pandemic. And if we will enrich patient inclusion by using biosignature, I think it's very important that the methods we use have quick turnaround times. And also, I want to say that I'm really impressed by everyone that contributes to these important RCT trials. There's a lot of hard work behind them, and thank you for this, and thank you everyone for your attention.
Thank you so much, Dr. Sara. There is a question from the chat. Which biomarker were used in PROVIDE trial?
Oh, in the PROVIDE trial, yes. It was monocyte HLA-DR expression and also ferritin levels to identify patients with a hyperinflammatory response. And in the adjusted inclusion criteria, they're using the level of 5,000 antibodies bound per monocyte as a cutoff level.
Excellent. Thank you so much, Dr. Sara.
Thank you.
We are moving to our next speaker. Niederman is a clinical director and as associate chief physician in pulmonary critical care at Cornell Medical Center. He is one of the leading scientists in ventilator-associated pneumonia prevention and the guidelines. The recent guidelines are from European Intensive Care Society. Also, he is an editorial board of the American Journal of Respiratory Critical Care and the chest. He will talk about the Macrolide for community-acquired pneumonia. The floor is yours, Professor Niederman.
Well, thank you. It's a real pleasure to be here, and I thank you for the invitation. This has really been a very exciting discussion today, and even though my topic is macrolide therapy and community-acquired pneumonia, I hope you'll see how it interacts, particularly with the last presentation. So my goal today is to examine the data about the efficacy of macrolide therapy for severe community-acquired pneumonia, but look specifically at some of the immunologic mechanisms that underlie the benefit. We published guidelines for severe community-acquired pneumonia last year, jointly for a number of European societies. And in those guidelines, we addressed the issue of macrolide therapy for severe community-acquired pneumonia. And when we asked the question, should initial empiric therapy for severe CAP include a macrolide or a quinolone as part of combination therapy to reduce mortality, we concluded that probably adding a macrolide was better and should be done routinely in severe CAP and better than adding a fluoroquinolone. And I'll try to give you some of the background for that and then some of the newer data that supports this. Years ago, there was this very interesting observational study from Medicare data looking at different populations of antibiotic therapy for CAP of all severity and days following admission. And if you used as the comparator group individuals who got monotherapy with a beta-lactam antibiotic, which is this purple line, there was an interesting unexplained observation that adding a macrolide to a cephalosporin or even using a quinolone alone was associated with reduced mortality. And the presumption at the time was that the benefit was related to the atypical pathogen coverage associated with either the macrolide or the quinolone. But I think we've learned a lot more since then. And so the question that I'll be talking about is the benefit of a macrolide in CAP due to the antimicrobial or the anti-inflammatory effects? There was another interesting observational study years ago breaking up bacteremic pneumococcal pneumonia into non-severe and severe pneumonia. And the interesting observation was with severe bacteremic pneumococcal pneumonia, the use of combination therapy, which generally did include a macrolide, was associated with much better survival than monotherapy with an effective beta-lactam antibiotic. Now, none of us were ever taught that you needed dual antibiotic therapy to treat effectively pneumococcal bacteremia, and yet there was this benefit of adding a second drug, generally a macrolide. And so this raised a number of interesting questions. There were prospective observational studies, as this one from Spain that looked at 200 intubated patients with CAP in a number of ICUs, most with severe sepsis and septic shock. And once again, treatment with a macrolide was associated with improved survival, but here the comparator group was a fluoroquinolone. So the macrolide, but not the quinolone, was associated with reduced mortality. So this raised some questions that maybe this wasn't so simple and maybe not related to an antimicrobial effect. And then this large meta-analysis looking at 28 studies, 10,000 patients with severe CAP, showed a clear mortality benefit for adding a macrolide to a beta-lactam in the treatment of severe pneumonia. And the benefit of a beta-lactam macrolide appeared to be better than the benefit of a beta-lactam fluoroquinolone. Once again, interesting observations not fully explained. There was an interesting study as well years ago looking at patients with CAP and sepsis. Many got macrolides within the first 48 hours, and macrolide use once again reduced mortality. But this reduction in mortality applied even if the organism was macrolide resistant. So this did not appear to be a clear and straightforward antimicrobial effect. And similarly, in a Greek study, double-blind randomized trial of 200 patients with sepsis and ventilator-associated pneumonia, randomized to use of clarithromycin or not as the intervention, where most patients had gram-negative, meaning Pseudomonas or Acinetobacter infection, and no impact of this clarithromycin on pathogen eradication. Nonetheless, as you can see here, the macrolide was associated with a shorter time to resolution and weaning. So numerous studies showed a benefit of macrolide therapy to improve outcomes in a number of patients with sepsis and severe forms of pneumonia. We did a study with Tony Torres' group a couple of years ago and asked the question whether the macrolide benefit was specifically associated with any specific pathogens or if in fact it was a general effect. And here, interestingly, use of a beta-lactam and macrolide was associated with lower mortality than a beta-lactam and fluoroquinolone. But the beta-lactam macrolide lower mortality only applied in those with pneumococcal pneumonia and a high level of inflammation, in this case, a high C-reactive protein. So this at least begins to suggest the possibility of looking at subsets of patients who could benefit from anti-inflammatory therapy, being those with specific pathogens and high levels of inflammation. There are a number of studies and a number of reviews that have documented the immunomodulatory effects of macrolides in community-acquired pneumonia. This is just one of the many older reviews that shows effects at multiple levels, both on the vascular endothelium, in the airway, and in the inflammatory cells, where there's generally a mixture of anti-inflammatory effects of macrolides that are potentially beneficial. We recently published, in conjunction with a Greek group, the ACCESS trial, which was a clarithromycin randomized controlled trial of early anti-inflammatory therapy in patients with community-acquired pneumonia who were generally classified as having severe community-acquired pneumonia. In this trial, which as I mentioned was double-blind, placebo-controlled, oral clarithromycin was given for 7 days. And again, this was the intervention arm. It was compared to beta-lactam monotherapy in about 300 patients with severe CAP, defined by SIRS and SOFA elevations and an elevated procalcitonin. And the primary endpoint was a composite endpoint of at least a 50% decrease in respiratory symptom score, no change with no change in therapy, and at least a 30% decrease in SOFA or favorable procalcitonin kinetics or both. There were a number of inflammatory endpoints looked at, included TNF-alpha, IL-6, IL-8, IL-10, and these were looked at serially throughout the study. None of the patients, although they were classified as severe, were on mechanical ventilations or pressors at the time of enrollment. The composite primary endpoint was met in a substantially higher number of clarithromycin patients than placebo patients. The odds ratio was 3.4 for achieving this composite endpoint with clarithromycin. And when we did clinical subgroup analysis based on age, smoking, COPD, with or without microbiologic confirmation, that benefit persisted. All components of the composite endpoint were lower in the clarithromycin group, along with a trend to lower mortality and lower readmission. And most of those benefits occurred in the first 8 days. This is, again, just a graphic representation of that composite primary endpoint. Interestingly, there was more TNF-alpha production by the polymorphonuclear cells at day 4 with clarithromycin than placebo. And when we broke down the immunologic response, quite surprisingly, what we saw was a early pro-inflammatory response that was greater with clarithromycin, but less immune downregulation, less immunoparalysis. So although we started the trial thinking that the benefit of clarithromycin was going to be purely anti-inflammatory, the true benefit appeared to be less immune downregulation, less immunoparalysis with the intervention with a macrolide. So the discussion again of whether the benefits of macrolides are antibacterial or immunologic is a complex one, but the benefit that we saw in bacteremia for macrolides did apply where it did not apply for quinolones. There was no similar benefit with doxycycline, some benefit with gram-negative bacteremia, which certainly doesn't fit with an antimicrobial effect, a benefit in macrolide-resistant organisms. Most of the benefit occurs with severe illness, and rapid resolution of septic shock in VAP with gram-negatives also suggests that this may indeed be immunologic rather than a microbiologic mechanism. There's a very nice review of immunomodulation of macrolides by Tom Vanderpoel and his colleagues, which I would encourage you all to read if you're interested in this topic. And I'll just conclude by saying that macrolides as an adjunctive therapy with beta-lactams improve mortality in severe CAP, probably by multiple immune modulatory effects. And in keeping with the theme today, we need to better understand if there are subtypes of patients who have a differential benefit. Thank you.
Thank you so much, Professor Niederman. I didn't see any questions in the chat. However, people are enjoying from their comment the overall sessions. I personally enjoy your session. I have a very interest in antimicrobial agent and sepsis. I would really appreciate your talk. For the sake of the time, I will move to the next speaker. Our next speaker is Dr. Alexander Vlaar. Dr. Vlaar is Associate Professor of Intensive Care Medicine from UMC Amsterdam. He is a leading physician and scientist in multiple international trials. He has more than 300 publications, and he's going to talk about modulation of complement. The floor is yours.
Thanks very much for the kind invitation, and thanks for the flexibility. So, modulation of complement in sepsis. These are my conflicts of interest. So, complement system is, as you all know, one of the oldest components of the immune system. It is a key element for destruction and also detection of invasive pathogens. And in that way, it is a strong amplifier of inflammation and coagulation. All good things. Except when we have an uncontrolled infection, this cascade goes on, and then there might be an imbalance between the positive effects of an activated complement system and the downside of this severe inflammation and coagulation, which may take place in sepsis. There are several ways to activate the complement system. We have the lectin pathway, we have the classical pathway, and we have the alternative pathway. Triggers which can be are PAMs or DAMs, the damage associated molecular patterns, or immune antibody antigen complexes, which all are able to activate the complement system, which goes through C3 with the release of C3A, and then of course also going to C5 with the release of C5A, the anaphylaxin, which is very strong and causing a lot of toxic ways to treat and target the invasive pathogens, but also a lot of collateral damage. The C5b is very important to take also in account, because this is important with your C6, C9 for the activation of your MAC system, which again is very important in controlling the risk of secondary infections. And this, of course, the topic we discuss now is complement modulation in sepsis patients is, of course, something very important to remember, because those patients are, of course, prone for secondary infections, and it's something what we would not like to happen. So if we look at modulation of complement in sepsis, there's a rationale, of course, for studying complement inhibitors. It's that excessive complement system activation contributes to sepsis-induced organ failure and death. And there are several case reports, case series on the topic, but if we really look in the literature, the number of randomized trials on the topic is still limited, and we are just hopefully at the beginning of the area to investigate, in which the C1 and the C5 targets have been studied so far. We look at C1 esterase inhibitor infusion, which was done in septic patients, randomization. It's a multi-center open label trial in which they investigated the influence of high-dose C1 esterase inhibitor administration on systemic inflammatory response and survival in sepsis patients. It was done in Russia, in surgical medical ICUs of 9 university and city hospitals, in which 61 patients with sepsis 1 criteria were randomized for 12,000 units of C1 esterase infusion versus conventional treatment. And what you do see here, adjusted for baseline characteristics, although quite okay balance, but still they did this multivariate analysis. They show that all-cause mortality was reduced by 45% to 12% by the intervention, as well as all sepsis-related mortality. What was not reported in the study was the incidence of secondary infections, again, which is important to note with the upstream interventions in complement. Another C1 targeted study was this study from Swiss. It assessed the efficacy and safety of the parenteral administration of C1 inhibitor to patients with severe sepsis or septic shock. It was a double-blind randomized placebo-controlled trial in surgical and medical intensive care units, in which 40 patients were randomized either for a C1 inhibitor or placebo with sepsis 1 criteria. Here it was a C1 inhibitor IV in 1 hour infusion, starting with 6,000 units, followed by 3,000, 2,000, and 1,000 units at 12-hour intervals, compared with placebo in the control group. What you see also on the top right figure is that patients in the intervention group had significant lower serum creatinine concentration on day 3 and 4 than placebo patients. So that's a very positive effect, of course, in line also with the previous study. But what here was noted were the number of secondary infections, and they were higher in the intervention group compared to placebo. So if we go more downstream, we've got anti-C5a, vilobelimab. This is studied in a phase 2a trial by Michael Bauer and colleague. It was studied to assess safety, tolerability, and pharmacokinetics and pharmacodynamics of anti-C5a, vilobelimab, a monoclonal antibody against C5a in patients with severe sepsis or septic shock. It was a multi-center randomized placebo-controlled phase 2 study in which 11 ICUs across Germany were recruiting patients. Patients with severe sepsis or septic shock with early onset of infection-associated organ dysfunctions were randomized in 3 to 6 hours after diagnosis, so very fast in this trial. 72 patients were randomized, 16 patients for each vilobelimab dosing cohort, with 8 patients for each placebo dosing cohort. So what they were able to show is that vilobelimab application was associated with dose-dependent decrease in C5a compared with baseline without detected safety issues. So complement activation in COVID-19, which is a viral-induced sepsis, is a very strong factor. It was already early shown that levels of soluble C5a were increased in proportion of the severity of COVID-19 and had high expression levels of its C5 receptor 1 in blood and pulmonary myeloid cells. C5a and C5 receptor have a key role in the activation and maintenance of several inflammatory responses by recruiting and activating neutrophils and monocytes. So this was also based on SARS-CoV-1 already, the first pandemic, in which it was seen that anti-C5a treatment showed for a better outcome in preclinical models. It was thought to try this intervention also in the SARS-CoV-2 pandemic. So we first did a phase 2 trial, which was published in Lancet Rheumatology, to assess the potential benefit and safety of selectively blocking the complement protein C5a with vilobelimab in patients with severe COVID-19. At that time, it was an exploratory open-label randomized phase 2 trial with 15 patients in the intervention group and 15 in the control. At that time, we thought PF ratio would be a very good primary endpoint. However, in the trial, there was no effect. What we did see was a significant effect on pulmonary embolism. And with this in mind, you could think of that anti-C5a treatment may improve the perfusion of the lungs. as there were less pulmonary embolism, thrombosis. However, if the lungs are not ventilated at that area, of course, your PF ratio will not improve. What was of interest is that we showed a significant improvement in outcome, in which there was a 30% mortality in the intervention versus 72% in the control. And we showed a very favorable safety profile with no increase in secondary infections. As with C5a selectively intervening, you still keep your MAC intact, and in that way, your patients are still protected with their own immune system against secondary infections. There is also no prophylaxis in antibiotics needed in this setting. So with the signal on outcome in the phase 2, it was decided to do a phase 3 trial powered on mortality. It was a global randomized double-blind placebo-controlled multicenter phase 3 trial in 46 hospitals in patients with invasive mechanical ventilated COVID-19 patients. We noticed in the phase 2 that the more severe patients actually seem to have the most benefit of the treatment, and that's why we decided only to enroll intubated patients. So 368 patients were randomized, 177 to vilobelimab at a dose of 800 milligram IV for a maximum of 6 doses, and 191 to matching placebo. All-cause mortality rate at 28 days was 32% in the vilobelimab group and 42% in the placebo group, just not hitting significance. However, we had a predefined analysis without site stratification, and this showed a significant reduction with a hazard ratio of 0.67. This also led to emergency authorization by the FDA. And the interesting thing is that we had an initial plan analysis without site stratification. However, on request of the FDA, they asked for a site stratification. So before finishing the trial, this was amended and changed. What turned out is that there were a few small sites, or not small sites, but because they were entering the study later on, they just enrolled a few patients with no deaths or only placebo enrollments. And this is something, especially as we did not know which arm the patients were, that the patients in those small recruiting sites were not put in the final analysis, because with site stratification, if there's no events in a site, it is not accounted in the final analysis. So in that way, we actually excluded 60 patients for the primary analysis. This is something the FDA noticed and agreed on, and they took also the without site stratification analysis as the basis for allowing emergency authorization for the use of vilobelimab in COVID-19. Of interest, predefined subgroup analysis, they showed towards a stronger treatment effect on 28-day all-cause mortality in the more severe patients. So based on the ordinal scale, but also the more severe ARDS patients or the patients with a lower eGFR, pointing out that really the effect of intervention on C5a in at least COVID-19, but this might also be of interest for future trials, is in this most severe patient group. So what we do know now is that upstream versus downstream inhibition of complement is important to take into account, especially if we see the signals. Also, if we look at the complement trials in COVID-19 were all negative, only the C5a downstream ultimate intervention had a positive effect, and the other trials, they were often neutral and were showing an increase in secondary infections. So really, we need to think about this in future trials. So think about the right patient population. We did also first a phase 2 trial identifying which patient group may benefit most, and of course the whole discussion on endotyping, phenotyping with a personalized precision medicine. This is something also what we should take into account in future complement trials. The right dosing and duration of treatment is also very important, as if you are too short, complement activation may come back, which needs to be thought of in the trial design. So concluding, complement modulation in sepsis is promising. Limited and only small randomized trials are present on the C1 level, there is association with lower mortality. However, there's also an increase of secondary infections. C5a inhibition is beneficial in mechanical ventilated COVID-19 patients with viral sepsis in a phase 3 trial, which also results in emergency use authorization by the FDA. The larger trials targeting complement upstream have failed, so really we should focus on the C5a. The role of C5a inhibition, there was already a phase 2 trial, but the confirmative phase 3 trial needs to be performed, and this will shed some light on this interesting topic. I thank you very much and happy to answer questions.
Thank you so much, Dr. Vlaar. Very interesting and very promising probably in the future. I would thank all the speakers for their contributions. I do have a question from the chat for Dr. Niederman. The question is related to pediatric with CAP. The comment from the question is they use Macrolide for pediatric CAP frequently until they were discouraged from the ID team. So the question is, do you think the data from adult population can be applied to pediatric as well?
Well, that's a very interesting question. And although I don't treat children directly, I suspect that the nature of the concerns related to pneumococcal resistance to macrolides. But if you look at the discussion that we had today about severe CAP, macrolides are always being used in conjunction with a beta-lactam. So if you think of the macrolide as an anti-inflammatory or an immune modulating therapy, in addition to whatever you think the best antimicrobial therapy is, I think it could certainly be applied to a pediatric population. One of the things I didn't say, and I think it's important to understand, is macrolides get discussed because they're well studied and they're studied for their immunomodulatory effects. But I don't think we should forget the fact that we're used to the idea of the macrolide class being anti-inflammatory. For example, tacrolimus is technically in the class of macrolides. And so I think what we're really looking for, and would avoid the kind of confusion that came up with this question, is a non-antimicrobial but immunomodulatory drug in the macrolide family that wouldn't have some of the adverse effects of stronger immunomodulatory drugs, but yet still the beneficial effects.
Thank you so much. I do have a question for you as well. I have a special interest in stewardship and sepsis, and I think pushing of using macrolide as an anti-inflammatory, it could open the fire between us and ID with the initiating more resistant to macrolide with treating patient for it as an anti-inflammatory rather than an antimicrobial agent. What would be your recommendation in this case?
Well, I think that's a valid question. I just don't think we have the data to know that short-term use of macrolides in the setting of severe CAP will have that adverse effect on efficacy of macrolides. And I think the starting point that was implied from the last question is that in many parts of the world, macrolides are already at a high enough level of at least pneumococcal resistance that they're no longer first-line therapy. So I think as long as you're aware of your local antimicrobial resistance rates and monitor that, I think we have to watch, but I don't know that macrolides being used as immunomodulatory therapy are really going to add to the already existing problem of macrolide resistance.
Very interesting. Thank you so much. Thank you so much for all the speakers. We still have around a few minutes. If anyone have to add any comments.
Yeah, I have a question for Dr. Cajander. She talked about immunoparalysis. How do you think we should be balancing immunomodulatory versus reversal of immunoparalysis in patients with severe infection? As I mentioned, we were very surprised by the results in our ACCESS study, and the reversal of immunoparalysis appeared to be beneficial.
Yeah, thank you. Thank you for that question. When it comes to reversing immunoparalysis in patients with different types of infection, if that was kind of your question.
Yeah, it was bad to be inflamed, but reversing immunoparalysis appears to be beneficial as well. Yeah, and I just want to add to that I think when we start to
if we would start to select patients by their clinical phenotypes and by the infection they have, I think that the patients that would be really interesting to start with are patients with difficult to treat infections, with Staph aureus infections that are complicated, where you see persistent bacteremia and those kind of patients to start with.
Thank you.
Okay, once again, I would like to thank all our speakers for their valuable contribution. I think the future will give us more evidence in precision medicine and sepsis. As we know, there is no one size fits all, and the science and the data will come up with more convincing evidence related to utilization of precision medicine and sepsis. There is another question, I think, again, about macrolide for pneumonia. What about the role of macrolide and anti-inflammatory drug? Would you consider corticosteroids?
Well, I think the corticosteroid question is an extremely complex one, and one that definitely needs to be better subdivided into individuals who can benefit. I don't think macrolides are identical to steroids in their effects, obviously, and I think it's beyond what we can talk about today. But interestingly, in the latest issue of ICU Management, which I just received a notice for yesterday, we wrote a review article about macrolides and steroids in severe CAP and point out some of the similarities and differences. So maybe for another day, that would be a very interesting discussion.
There's a follow-up question for you as well. Would you recommend using macrolide associated with beta-lactam in patients with severe community-acquired pneumonia?
Absolutely. It's my first choice for treating severe CAP. The one maybe exception to that, and it's a relatively uncommon occurrence, but I think if you have highly suspected or documented Legionella infection, then maybe a quinolone would be a better choice as a second drug than a macrolide. But I don't think the immunomodulatory effects are so clear for the quinolone. So in general, if you're not treating Legionella, I think knowing that the recommendation for severe CAP is always to use two drugs, never to do monotherapy, and generally the first therapy is a beta-lactam for a variety of reasons, I would certainly make the macrolide my second drug in that combination regimen.
Thank you so much, Dr. Niederman. Thank you to all speakers. I would also thank the attendees for their contribution and time and their valuable questions. Thanks for our sponsor, and I will take this opportunities as well to invite you all to visit the Global Sepsis Alliance website and sign the Declaration of Sepsis. All these sessions are recorded, and you can find them in YouTube and podcast. There will be a scheduled weekly release, and I wish you a beautiful rest of the day or evening, depends on your time zone. Thank you so much.